Welcome to the second Renal Week podcast on today, November 19th. We're back in beautiful Denver, Colorado, with a convention center that has as one of its hallmark features of a bear looking in the window. I'm not entirely sure what that bear is looking at, but it's a remarkable feature. The convention center is beautiful. It's large and airy and breezy, and probably the best part of this convention center is that it's allowed all of us to get some exercise going from one part of the convention center to the other. So we should all come back to our jobs much more in shape than when we left. Today I have with me three distinguished guests: Dr. John Sedor from Case Western in Cleveland, Ohio, and another Ohioan, Dr. Prabir Roy-Chaudhury from Cincinnati, two parts of the state of Ohio, and moving slightly away, again in a Midwestern state, Dr. Millie Samaniego from the University of Michigan. Welcome to all of you. What I'd like to do is to start out by thinking about the morning session. We had two really interesting talks, one that pertained to dogs. Yesterday we learned about how important pigs were in cystic fibrosis and science in general. Today, John, we learned about the role of using dogs in genetics. Can you tell us about what you learned today?
It was a terrific talk. I think, my initial thoughts when I saw the title was, what was this going to be that would apply to what I do? And I'm interested in genetics, and I think it's another example of how you can learn a lot from particularly non-traditional model organisms. And it was just a beautiful demonstration of, perhaps for the scientists, different methodologies that could be applied to complex traits like chronic kidney disease in humans, as well as how things that you learn, genes that are discovered in other organisms, in this case the dog, provide leads and insights into human disease. And she concentrated on cancer, bone disease, size, but it was just a terrific presentation.
So Dr. Ostrander from the NIH, who gave that talk, started her presentation by asking us the question of what was the difference between a very small dog and a very large dog, and then went us through the rough coat, smooth coat demonstration. Can you just recall some of that most interesting work that she presented?
She started out, with a fundamental issue, which was different in sizes and how they sorted out, and basically identified a single set of markers in the genome that identified a gene that absolutely made sense. Insulin growth factor 1 being critical in regulating the difference in sizes in dogs, went through a lot of other normal phenotypes, and then she ended up with focusing on her work in cancers in dogs and the insights it's provided to human disease.
But don't you think you'll never look at a dog again without wondering what kind of coat they have, and whether they're small or whether they're large, and then of course whether you have curly hair as a human or whether you have straight hair?
Right, absolutely, and whether or not you have a mustache.
Exactly. What did you think of that discussion, Prabir?
I thought it was a great lecture, and I really thought that the combination of the lecture yesterday on pigs and this one on dogs, in a way it came together, because there was a message in there, I think, for everybody, not necessarily the basic scientists. I think the message for the clinician was that maybe the clinician's going to go back and ask a few more questions to the fellow. It's going to make clinicians, I hope, more curious about maybe the patients that they see. And for the researcher, of course, I think it's awesome to see the sort of work that she presented, and hopefully it'll help some researchers to maybe go into a different direction. So I thought the combination of those two translational lectures was just superb.
So the other lecture that you're referring to is Dr. Kritz's lecture, who gave the Homer Smith Award lecture. His main initial message was that we were forgetting the science of morphology, and that we needed to go back and look under the microscope and recall all the wonders that we learned in medical school.
I thought that was a great lecture. In one phrase, I think he really made the point that morphology or anatomy remains king. And I think the second message that came out from that lecture was that it was impressive to see somebody go so deep and be so meticulous in one area. And I think that that's inspiring to a lot of people, that he spent his entire life, 35 plus years, really dissecting out the morphology of the glomerulus and the tubules. So very impressive.
Millie, what did you find interesting in today's sessions?
Well, from the transplant standpoint, we have three interesting sessions. The first one was this afternoon, a meeting within the meeting session, where there were several presentations that went from the modification of donor organs to induce tolerance by modifying or inducing the production of specific cells such as plasmacytoid dendritic cells that can decrease the immunogenicity of the transplant. That I found that extremely interesting.
So you have been a leader in this transplant field for a long time, and tolerance has been talked about for a very long time. Did you hear new insights today that will allow you to understand tolerance, or perhaps allow a tolerogenic moment in one of your transplant patients?
Well, I think that it's going to take more than what we learn or we have done until now to induce tolerance. In what I learned today, I think it will be a combination between what we modify in the donor organ and at the same time what we modify in the immune system of the patient. To that end, there was an interesting presentation by Bob Gaston reviewing the most recent trials on belatacept, which is a costimulatory signal blockade. And in these particular trials, one interesting observation has been that although there is quite a little bit of acute rejection early on, those organs who have acute rejection at the end up having better outcomes in terms of function and graft survival than even those who were not treated with the medication and did not have rejection. So it suggests now that in order to induce a better immune response towards the organ, initially we need or we require some level of injury that will be reversible, and this drug seems to be facilitating this. The other important aspect of this drug is that it seems to inhibit alloantibody production even if rejection occurs. An alloantibody has come up to be the most serious problem that we are confronting to ensure a better survival of kidney transplants.
The real problem, of course, with our transplant program is we don't have enough organs, and we have so many patients on our waiting lists. There were many sessions, I gather, about waitlist management or dealing with patients on the wait list. What do you think of?
The management of the patient and the waiting list is a serious problem that requires active involvement of the general nephrologist, since the majority of these patients are followed in dialysis units by the general nephrologist. The problem we have in the management of these patients is that there is really no solid data that could guide the community to pursue one workup or the other. So if the patient wants to be followed for the risk of cardiovascular disease, the data shows that even in patients that undergo aggressive workup, only 10% of patients or less end up requiring revascularization. And if we looked at this in a randomized fashion, there is no difference in cardiac events if the patient undergoes revascularization or not. So we still do not know what is the best pre-transplant cardiac workup that we should do in the waiting list to reduce cardiovascular disease.
Prabir, you were one of the individuals who pushed the American Society of Nephrology into wanting to expand into areas that the ASN has typically not ventured. In that regard, you've been most interested in developing a bioengineering opportunity here at the ASN. This is the first year that an abstract category was even available. Were there any responses to that abstract call?
I was absolutely delighted that the ASN had this new abstract category on bioengineering and informatics. We had the poster session today. I thought it went off really well. There was a lot of energy, there was a lot of excitement, and the nice thing about this, having bioengineering as a single entity, is that you get all these people from diverse backgrounds, engineers, radiologists, basic scientists, biophysicists, molecular biologists, and clinical nephrologists, really all coming together. And I think that it's this sort of poster session that's going to promote cross-fertilization between different specialties. And just to give you an example, there was a poster, for example, on how shear stress of fluid within the tubules affects tubular function. And then two posters next to it, there was a poster on hemodynamic shear stress in arteriovenous grafts. And then a little bit further down, there was a poster on a clinical algorithm to make sure that people get the right dose of EPO. And then two posters away, there was a poster on how you can stimulate T cells to make EPO. So, I think that there really was a lot of excitement and enthusiasm. And I think there were people who perhaps would not have otherwise come to the ASN. There was an engineer, for example, whose main interest was MRI, and he was absolutely delighted that he had this session, and he was so thrilled that he could actually ask nephrologists questions about the kidney, because they had this incidental finding that when they did MRI with a particular type of cationic substance, it actually lit up all the glomeruli. And he was asking, why do you think some of the glomeruli are lighter and others darker, and what does that mean?
So why do you think that happens?
I don't know. I think it may, maybe there's, I think it's linked up to perfusion, and, maybe it's, juxtamedullary glomeruli are different, but it's just, I would never have thought of using MRI to try and find out why some glomeruli may be different in one part of the kidney from the other. So
the renal pathologist won't like any new approach to non-invasively diagnosing glomerular disease.
I think we're still some distance away from that, but it was good fun. It was good fun.
Good.
I think that session was terrific. We did something unusual for us, and we put a biomedical engineer on our training grant a year ago, and he was presenting his work on the bioartificial kidney and was actually looking at shear stress in tubules, and he thought it was terrific. There was a community here for him, and he felt more engaged. And one of the reasons he chose to come to a physician's lab, he works with Bill Fizell, is because he wants to apply his engineering skills to medical problems. So it was wonderful that there was that opportunity here.
So John, you're a senior leader in nephrology. How do you motivate young investigators to embark on what otherwise would be a non-traditional pathway within the nephrology community?
Are you talking in terms of non-physicians, or?
Well, bioengineering is not a traditional pathway within nephrology. How do you motivate individuals to move into these new directions?
Well, I think we have to really highlight the breadth and the excitement that's going on in nephrology. And every year when I come to this meeting, I realize how fast our science is moving forward, the kind of advances that are being made now. And we're certainly doing as well, if not better, than a lot of other areas of medicine that traditionally get more play than we do, like oncology, perhaps infectious diseases. And when I'm recruiting people that aren't physicians, I tell them about the things that are going on, and having those sorts of methodologies, techniques, ideas showcased here just really brings home the fact that they didn't make a mistake, and gets them excited about wanting to pursue their career and write grants and soldier on.
So what's the best way of increasing the number of those individuals who want to enter the nephrology space, who want to have careers in the broad spectrum of kidney disease? Where do you find those individuals?
I think you have to take advantage of opportunities to talk about what's going on in the field. I think the prime thing that motivated me to go into nephrology was contact with senior nephrologists that were in the field then. And I think now, because of the pressure of time and commitments that we all have, we need to be out there talking about what's going on and getting people excited about what we're doing.
So, Prabir, you're an interventional nephrologist.
Well, I'm very interested in that field, and we have an interventional nephrology program, and I hope to become an interventional nephrologist.
But you have been instrumental in trying to push that general environment forward. Are more nephrology fellows interested in interventional aspects?
I think there is a huge interest amongst nephrology fellows for interventional nephrology, and I think that as interventional nephrology grows, I've always felt that we're going to be pulling into nephrology maybe a different type of fellow. I think we're going to be widening our net in terms of the types of residents who want to come into nephrology, and I've always felt that there are many fellows or many residents who go into cardiology because they love opening up vessels and they like interventional procedures, but a lot of them actually have a very academic bent. So they like nephrology, but they don't go into it because there are no procedures. And I think we may actually attract in a lot of additional residents by having interventional nephrology. Linked to that, if I may, I think the other thing that it's important for us to point out to medical students and residents is that we are such a diverse and broad specialty. I mean, we go all the way from immunology and transplant and SLE to biophysics and biomaterials in dialysis, to long-term primary care of the dialysis patient, to interventional procedures. And it's really important for us to get that message out. And there was, in fact, a really nice poster session about education, about using new methods, role playing, for example, having little stories about nephrology. And, I think that was a great poster session about how we can make nephrology more interesting, both to our residents and to medical students.
And John, you have made a career out of studying genetic changes in our population. What interesting genetic studies did you have the opportunity to see today?
Well, there was a session this afternoon on genome-wide association studies, and each of the major consortia gave a progress report of where their results were. So Carolyn Fox presented the data from CKD-GEN and discussed some of the data that had been published in their efforts to move forward. FASN Parsa discussed the CRIC study, and Sudha Iyengar presented our data from FIND. And I think one of the take-home things that I learned was that the genes that we're working with in the FIND consortium are different from those that Carolyn talked about in CKD-GEN, suggesting there are different triggers for initiation, maybe progression, and then the end-stage disease that we study. And the consortia together are studying various aspects of that pathway of chronic kidney disease. So it was quite an interesting session. It was a nice seg to yesterday's session where Martin Pollack and Jeff Kopp talked about the exciting data with ApoL1 and African-American end-stage renal disease.
Is there a way for all of these consortia to get together to pool their data, to learn from each other?
Absolutely. And in fact, one of the nice things about the session is everybody was there, including people from Europe. And there was a lot of discussion afterwards about how we're going to get together and do that. And there's some concrete plans for that to be happening.
So John, a huge amount of what happens at this wonderful meeting does not actually occur in the confines of a session. It occurs over lunch or it occurs in the hallways. How do you simulate that kind of really important discussion?
Well, I mean, I think it's an effort for people that are working with others elsewhere. We certainly made an effort. There are people I've only talked to on the phone that are in Germany, and we had the opportunity, everybody was here to get together and meet each other, and it really solidifies the collaborations and friendships that are growing from the collaborative science we're all doing now.
There's a little bit of a feeling that genome-wide association studies may not provide as much information as we would have hoped several years ago, but yet when you hear the beautiful work that this morning from Dr. Ostrander with respect to her dog models, can you envision taking the information that you now know from the consortia studies in humans and think longitudinally where those studies could go with all of the wonderful technology that Dr. Ostrander talked about this morning.
Oh, absolutely. And I think the APOL1 story is a good illustration of that. In fact, the previous report from Find and Jeffrey Kopp that identified the MYH9 gene actually gave us a position in the genome that allowed Martin to pursue that and then ultimately find the causal variant. So I think we're just at the beginning of an exciting time that the positions that are being identified are pointing out regions in the genome that need to be studied. The other thing that I'd like to make a point about, there's been considerable amount in the popular press about GWAS being disappointing, but in fact, you can't confuse the effect size in a genetic study with the functional significance. And a great example of that is the work that's been done in lipid genetics. In fact, the HMG-CoA gene has a very small contribution to overall lipid levels, but in fact that's the target for statins, which have had a fundamental impact on cardiovascular risk. And hopefully we're on our way to finding similar stories with kidney disease genetics.
Humans tend to be outbred in contrast to the inbred, multiple inbred strains that we heard about this morning in dogs.
It's interesting you say that, Ron, because the fourth talk in the session this afternoon was from Linda Cow, who has been working to try and make associations across people of different ancestry. So we're working in almost the same ways that Dr. Ostrander was working in dogs.
One of the benefits of nephrology is there have been a number of registries, large population registries. Of course, the USRDS is probably the best of these registries, but there are registries within multiple disease groups as well that may provide a basis for a number of these studies if DNA and genetic material is obtained. But Prabir, you actually went to some of the USRDS registry discussions. Can you tell us about those?
I went to some of the USRDS and DOPS discussions. I think one of the things that came out particularly from the DOPS was that there's a huge mortality in dialysis patients in the first year. And there was a very elegant study which dissected out the different factors that resulted in that increased morbidity. And not surprisingly, the biggest contributor to that increased mortality in the first year was catheter use. And then there were other modifiable factors, but really catheters, and up to 80% of patients start dialysis with a catheter. That really seems to be a big problem.
Prabir, we've been worried about catheters now for a very long time. What can we do to decrease the number of patients who start with these plastic devices?
I think we need to shift our emphasis from the dialysis population to the CKD population. And it's not easy to do. Multiple logistical, communication, education, insurance issues. But I think that's the only way that we're going to reduce this huge incident rate of patients starting dialysis with catheters.
There have been articles just recently in press that suggest that we here in the United States are not doing a very good job in our dialysis program. What you're suggesting, I guess, is that we ought to shift our attention not only to the optimum care of patients in our dialysis units, but earlier on, either in preventive strategies or to intercede with our general practitioners and family practitioners to be able to interact with those patients earlier on so that they never have the opportunity to have a catheter, to have the opportunity to have a fistula first.
Absolutely. And it's not about rocket science, it's about logistics, communication, education, interactions.
Easier said than done, and we've all tried it for a long time, but we must continue working in that vein.
Absolutely.
Millie, in terms of other populations, there were studies and discussions today about living donation and transplant. Can you share with us some of those observations?
There were several posters presented today from different parts of the world. There was an interesting poster from North Carolina where they investigated the effect that legislation providing tax breaks for living donors, the impact that has had in living donation. And actually, they found that compared to states that do not have such legislation, these tax breaks have not resulted in greater living donation at those places. I think that some of it has to do with the fact that the population that donates is usually relatively poor and are not in a very high tax bracket, and therefore do not benefit from whatever legislation has been passed. There were also reports from the Korean experience about providing incentives for donation and showing that their outcomes have not been affected by providing living donors with monetary incentive for donation. And the Iranians also reported on their follow-up of the living donors that have donated after being offered monetary incentives, and the outcomes were relatively good.
So from that experience, should we be changing our practice of living-related donation here in the United States?
Oh, that is a very contentious topic, and one that will be addressed in a session tomorrow. There are two camps, the camps that opposed donation incentives 100%, and others that support some sort of incentive, providing medical insurance to these patients, including these patients into Medicare early on. But the jury is still out on that one.
So, Millie, I'm going to press you a little bit here and ask you to come down with a recommendation.
Well, if I had any power on policy making, I will encourage these patients to be linked into the Medicare system early, particularly those who do not have medical insurance. A substantial number of our living donors do not have medical insurance, and many of those who have it lose it because of the economic situation of the country right now. Those patients should be provided with access to medical care, and the government should provide that.
One of the interesting parts of this meeting, or any big meeting, is to learn more about your own particular field. So in my experience, I like small vessel vasculitis and learned today in that arena that patients who use cocaine develop vasculitis. But they don't develop vasculitis from the cocaine, they develop vasculitis from the levamisole, which is used to cut the cocaine. It apparently has the same temperature melting point and the same texture, and so you can decrease the amount of cocaine in a cocaine brick. A completely novel sort of thought, even within my own area that I think I know something about. But one of the fun parts about the meeting is to interact with individuals with whom you have hardly anything to do with previously, and more importantly, areas of knowledge which really you know absolutely nothing about. So John, how do you interact with individuals or try to learn from people in arenas that are very far from your usual daily parlance?
Well, when I am thinking about what I'm going to do at the meeting, I usually identify sessions on things that I'm not actively involved in. I don't do much with dialysis patients, even in my clinical practice as in the acute setting. And I take the opportunity here to learn what the best practices are in managing ESRD patients, particularly in the outpatient unit. Helps me in my teaching, helps me in my practice when we're discharging people from the hospital.
So John, do you take a dartboard and you throw a dart in the book and figure out what area is fundamentally different? How do you actually approach that issue?
Well, actually, I go to the website just before the meeting and get a handle on what's being presented and start picking out sessions that I think would be instructive to me and plan in advance. The meeting, as everyone knows, is huge, and the years I haven't done that haven't been as effective as the years I've actually put a little effort on my way to the meeting to plan what I'm going to do.
So you're telling me that the dartboard strategy is really an ancient one and that everybody should go to the web, especially the new improved ASN website, and figure this out in advance?
Absolutely.
Prabir, how do you do this?
A mix, really. You know, I think it is important to go through the program, and I try and pick out some sessions that are not in my area. I may have seen a patient with, say, acute kidney injury, and there was a journals club or a discussion about it. And so I picked out yesterday, I went to one of the AKI sessions. I learned that there's still far more questions than there are answers. So that's one way. The other thing that I do recommend, though, is that we have all of these beautiful technological advances that you can put in keywords and you can get out a list of abstracts that you should go to. I think you should have some lateral thinking. So I pick out a poster session that is sort of linked to my area, but then I just browse through it. I mean, I don't pick out a particular abstract to go to. I just sort of walk through it. And if I see a heading that, that piques my interest, I stop. And then sometimes I just keep going beyond the end of that poster session, and I go into the next one, and I just look at those posters, and it may be totally different from what I'm interested in.
So Prabir, put yourself now from the perspective of a very young investigator who has come to this meeting for the first time, and there Prabir Roy-Chaudhury is wandering down the poster path. And what would you suggest to that young investigator to get you interested in what they're doing?
If they're at the poster, I think some eye contact is really important, because then I stop. I always stop, because that tells me that this person wants to tell me about his or her work. And I think that I have always been very open to hear. I mean, if I see somebody making eye contact, I say, well, tell me about your poster, because it's much easier to learn about a poster that you know very little about by having somebody speak to you about it. And, I think a lot of the advice, my sort of message to young people would be that mid-level and senior people want to see young people present their work, and sometimes I see them cringing at one end of the poster, looking down, doing everything not to catch your eye. I would say, doesn't matter, just look straight in the eye of the person, be aggressive, grab that person and say, I want to tell you about my poster. And I think you'll find a lot of people will actually come and listen.
So Prabir, what you're almost suggesting to a certain extent is we should all take lessons from the facilitators on the exhibit floor, who are very, very effective in getting one into the exhibit booth. They're fantastic at it. So maybe we should all provide our trainees with that sort of training prior to going to the ASN.
Yeah. Just one other thing about trainees. I think a bit of advice in a way for trainees, because often, when you come for the first time to ASN, this is huge. When I first came to my first big meeting, it was just too big. And one of the things that I would say is, take things at your own pace. You don't have to listen to everything. You don't have to go to every abstract. Just go to ones that are interesting. Do some lateral thinking. Ask people in the evening, what did you find interesting? And you'll get a flavor of the meeting. You don't have to rush to go to every single session that you've checked off. I would just take it a little bit laid back.
One of the advantages this year is the ASN is recording both the slides and the oral discussion of 300 hours of contact time, both from the in-depth courses as well as many of the sessions now. So presumably one will have the opportunity to go back home and listen to some of those talks, either again if one didn't understand them the first time, or perhaps in areas that otherwise you wouldn't have listened to.
That just makes it a lot easier to just go to a few sessions that you're interested in, have a more laid-back attitude, have some more fun.
Millie, how do you approach the meeting?
Well, usually before we come to the meeting, we amongst the faculty, we decide, well, what areas are you interested in going over and learning about? And so we sort of distribute between ourselves the different areas. Usually it can be the transplant area, or it can be electrolytes or acid base or bone metabolism. And each one goes and listens to different lectures. And when we go back home, then we get all together and discuss the lectures that were more interesting, the posters that were more relevant, the free communications. In my particular case, I usually go through the day at glance. It helps me a lot to identify which particular session, symposium, clinical science conference I can attend. Also for the meeting within the meeting, that menu of the different lectures is very useful.
So Millie, what advice would you give to the young investigator that wants to have Millie Samaniego stop and examine their work?
Well, I would say I would agree that direct contact and a smile, or even if they see the person standing and looking at the poster, approach them and say, do you have a question? What would you like to know about this program? Let me explain to you what is the hypothesis behind this study. Unfortunately, I agree that the fellows are a little shy. And perhaps what we should do is to tell them that this is a great opportunity to not only have their research critique in a friendly environment, but also an opportunity to get ideas from the senior people that go read these abstracts and say, well, have you considered to look at this particular question in this way or this other way?
So John, I'll give you the last word on this. What would you tell a young investigator to get John Sedor to stop? I
think I would just echo what you both said. I think it's absolutely right that you just stop and talk to people. And I think I always tell our fellows, you'll be surprised how welcoming almost everybody is. The faculty, the senior investigators, people from other institutions are always interested in talking.
I want to thank all of you for a really interesting and stimulating and wide-ranging discussion on this second day of this portion of Renal Week. Thank you so much for your time and your thoughts. This is Ron Falk for the American Society of Nephrology.